Preoperative Workup for Pheochromocytoma Introduction. Welcome back to the Everything Surgery podcast, where we break down complex medical topics for clinicians and learners. Today, we are walking through the preoperative workup for pheochromocytoma, an adrenal gland tumor that can have significant implications for surgical care. The approach to preparation involves several critical steps. First, confirm the diagnosis through biochemical testing. Next, identify the location of the tumor with imaging. It is also important to determine if the tumor is malignant or has spread. And finally, to medically optimize the patient to ensure a safe surgical procedure, focusing particularly on alpha-adrenergic blockade and expansion of blood volume. Biochemical diagnosis. Confirmatory testing. First-line tests. The most reliable and sensitive method for confirming pheochromocytoma is measuring either plasma-free metanephrines or 24-hour urinary fractionated metanephrines. These metabolites offer a sensitivity greater than 95% and a high specificity, making them superior to directly measuring catecholamines. Plasma-free metanephrines. This test is generally preferred because of its convenience, but it is important to collect the sample while the patient is at rest, lying down, and to minimize any stress beforehand. 24-hour urinary metanephrines. This is an alternative when plasma results are inconclusive. Avoid measuring serotonin or dopamine metabolites, unless there is a strong suspicion for dopamine-producing tumors or related genetic syndromes. Imaging for tumor localization. First-line imaging. Cross-sectional imaging such as computed tomography or magnetic resonance imaging of the abdomen and pelvis, preferably with contrast unless contraindicated, is recommended. Magnetic resonance imaging is especially useful in pregnant women and younger patients, as it avoids radiation and can reveal the classic light bulb sign on T2-weighted images. Computed tomography provides exceptionally detailed images, which aid in surgical planning. Functional imaging. This is important for patients with tumors outside the adrenal glands, those with evidence of metastatic or recurrent disease, or when a genetic predisposition is suspected. Gallium-68 positron emission tomography or fluorodeoxyglucose positron emission tomography are both highly sensitive, particularly for tumors with somatostatin receptor overexpression or those related to succinate dehydrogenase mutations. While iodine-123 mid-iodobenzylguanidine scintigraphy was historically used, it has been largely replaced by newer imaging modalities except when considering patients for iodine-131 mid-iodobenzylguanidine therapy. Genetic testing. It is important to recognize that up to 40% of pheochromocytoma and paraganglioma cases have a hereditary component, with genes such as RET, von Hippel-Lindau, neurofibromatosis type 1, succinate dehydrogenase subunits, MAX, and TMEM127 implicated. Recommendation. All patients should be offered germline genetic testing, as this significantly influences both surveillance strategies and long-term management of the patient and their family. Preoperative pharmacologic preparation goal. The aim is to control blood pressure, prevent dangerous increases in blood pressure during surgery, and avoid low blood pressure after the tumor is removed. This is achieved by starting with alpha-adrenergic blockade, and adding beta-adrenergic blockade if needed. Alpha-adrenergic blockade. Phenoxybenzamine is the agent of choice. It is a long-acting, non-competitive blocker of both alpha-1 and alpha-2 receptors. It should be started 10 to 14 days before surgery, with doses gradually increased from 10 mg twice daily up to 1 mg per kilogram per day. The goal is to achieve seated blood pressure below 130/80 mm of mercury, some degree of orthostatic hypotension, and resolution of spells. If phenoxybenzamine is not tolerated, selective alpha-1 blockers such as doxazosin, prazosin, or terazosin can be used. Calcium channel blockers like amlodipine or nicardipine are alternatives or can be added for additional blood pressure control. Beta-adrenergic blockade. Never initiate beta blockade before adequate alpha blockade, as this could result in unopposed alpha-adrenergic activity and precipitate a crisis with dangerously high blood pressure. Beta blockers are introduced only if the patient has a resting heart rate above 80 to 90 beats per minute, or arrhythmias. Selective beta-1 blockers such as metoprolol or atenolol are preferred, but non-selective beta blockers like propranolol can also be used if necessary. Volume expansion. Because alpha blockade causes blood vessels to widen and the circulating blood volume to decrease, it is critical to restore intravascular volume in the days leading up to surgery. Patients should be encouraged to increase their sodium intake to more than 5 grams of salt per day, and to drink plenty of fluids 1 to 2 days before surgery. This helps prevent low blood pressure after tumor removal. Careful monitoring for orthostatic hypotension and swelling is necessary. Additional preoperative assessments. Cardiac evaluation. All patients should undergo an electrocardiogram and an echocardiogram to check for evidence of heart muscle problems or left ventricular dysfunction caused by excess catecholamines. Anesthesiology consultation. A preoperative meeting with anesthesia is important to plan for intraoperative management and ensure team readiness. Medication review. Patients must stop drugs that could trigger a hypertensive crisis, including tricyclic antidepressants, monoamine oxidase inhibitors, sympathomimetic agents, and dopamine antagonists such as metoclopramide. Preoperative intensive care unit bed. It is advisable to arrange for an intensive care unit bed for close monitoring after surgery. Special considerations. Malignant or metastatic disease. These patients require a multidisciplinary approach, and may benefit from preoperative therapies such as iodine, 131-methyliotabenzylguanidine or peptide receptor radionuclide therapy. Pregnancy. Use magnetic resonance imaging without contrast to localize the tumor, and alpha blockade with phenoxybenzamine. Timing of delivery and surgery should be carefully coordinated based on the trimester. Pediatric patients. There is a higher rate of hereditary and multifocal disease, making genetic testing especially important in children. Summary of key steps to recap. The essential steps in preoperative workup for pheochromocytoma include biochemical confirmation with plasma or urinary metanephrenes, tumor localization with computed tomography or magnetic resonance imaging, and functional imaging if needed. Genetic testing for all patients. Medical preparation with alpha-adrenergic blockade and volume expansion, followed by beta-adrenergic blockade if indicated, and coordinated planning with endocrinology, anesthesiology, and surgical teams. Conclusion. In conclusion, a careful and systematic preoperative workup is crucial to minimize complications and improve outcomes for patients undergoing surgery for pheochromocytoma. Thorough medical preparation is just as important as accurate diagnosis and tumor localization. Thank you for joining us today. If you found this episode helpful, please like, share, and subscribe. This has been the Everything Surgery Podcast, where we dissect the extraordinary.